Good afternoon. My name is Doug Dahl. My normal job is Communications Officer for the Parkland Health Region. I've been co-lead on RPIW number 52. This is our report out, standard work combination sheet, giving you our agenda. We will be reporting to a back time of 20 minutes. This is our team and the wonderful backdrop of Evergreen Health Centre in Leoville, which has been our home for those of us on the team for this week and a few other days previously. RPIW 52 is about improving consistency of care and utilization of MDS by utilizing CAPS on 100% of long-term care residents. So MDS is minimum data set. It comes from an internationally recognized assessment tool, and CAPS is clinical assessment protocols. You'll be hearing people use MDS and CAPS throughout this rather than repeating all of that. Our job is to try to create a process that this is being done to improve care planning. Prior to the event week, we did a SWOT analysis. We looked at strengths and weaknesses, opportunities, threats that we had to getting care planning done properly, better, improving it for the residents. A lot of it is a lack of understanding of the system and the tool. There's also challenges in communication between team members about what's in the care plan. So this week we really focused on trying to improve and address all of those.
Good afternoon, my name is Kathy Iverson. I'm the Assistant Director of Long-Term Care for the region, and part of my role includes being the MDS coordinator for both long-term care and home care. So for this year, there's a provincial priority for long-term care, and that involves long-term care facilities in Saskatchewan, meeting the goal of meeting the benchmark targets established for 7 quality indicators, and that's by March 31st, 2017. So currently the ministry is monitoring 7 quality indicators in long-term care, things like restraint use, falls, inappropriate use of antipsychotic medications, worsening pain. So we want to develop a process where we are proactively addressing and creating a care plan for our residents to provide that safe quality care instead of reacting to being above the target in the QIs. So the current state, the value stream map, so the current process is there's information gathered to complete the MDS assessment tool. From there, there's outputs that are generated, like the clinical assessment protocols to develop your care plan. Currently, we do have inconsistencies in the process of completing the care plan, how the CAPs are utilized to complete the care plan, and the communication. We need to do a better job of communicating with our residents, our families, our care team partners to provide that safe quality care. So one way that we've addressed some of those gaps, as we noticed in the Kaizen burst, was to create an information flow chart. So the green arrow is like an internal feedback loop. So it addresses that current value state, current value stream map, where we get our info, we complete our assessment, we do the care planning, but now we really need to ensure that we are communicating that to our residents, families, the care partners, involving them in planning that care and implementing it, and then it flows back up and the process starts over again. As well, the blue and the red arrows, we have provincial and national analysis of our MDS data. And from that, that flows back down through the regional health authorities, the senior management, the staff, the public, our residents and families. And we need to ensure that that's flowing back into our internal feedback loop.
Hi, I'm Angela. I'm a CCA in Louisville. So through this process, we recognize that we haven't been using the tools provided to us the best that we possibly can to provide the best resident care possible. And also the communication gaps between the care teams and residents and families. Here we show that the residents and families are not aware of the outcome measures, the scores from the MDS, and the communication gap between the care team and the residents and families. So proposed solution to review CAP's outcome measure scores at annual resident family care plan reviews, the meetings, and passing our information on to the residents and families so they are aware of what's going on. And here, a problem we're recognizing is the care team was not using the MDS and CAP triggers for gathering information for residents and the resident family care plan meetings. And the proposed solution, proposed to print off the CAP triggers before the resident family care plan meeting and to use the outcome score measures to help fill out the areas that needed to be addressed and acknowledged at the 3-month med reviews.
Hi, my name is Estelle, and I'm a LPN in Spiritwood. So we had already some existing work standards, but we updated them to provide residents and families the knowledge of outcome measures to support our care planning process. And our first one here was the family resident care plan review, and we updated the care plan review meeting script to standardize it for everyone, to inform the family of the intent of the meeting. And then we added more healthcare team workers to be able to attend if they so wish. And a week prior to the review, we remind the resident of the review date. There's nothing about me without me. Resident is to attend, participate as they wish. And at the review, we review the CAP triggers and bedside care plans and outcome measures to assist in educating families during the review. We also update the CAP care plan face sheet with any changes. We forward a copy to the DOC to review and update. And these will be done 6 weeks post admission and annually. And there's one form for both meetings. Now the other one is the resident 3-month medication review, and that's to include the physician and the pharmacist and a family resident member if they so wish. And that we added, we pulled the CAPS and outcome measure scores from the most recent MDS assessment, and we used to complete the checklist. And we also added in our self checklist is we added the triggers, the CAP triggers, so that we can do the care plan better. And also we reviewed the CAP triggers and outcome measure scores in the medication review process.
Hello, I'm Alicia, a long-term care educator in the region. So problems we identified was who is responsible to do MDS, where do we get data for MDS assessments, and what is the process? Solutions were to create a work standard. The work standard outlines the responsibilities that the nurse is responsible to complete an MDS assessment, and they will be assigned. The work standard identifies and what goes into the assessment, what documents that you're looking at, what criteria you're taking into account for your assessment and what time frame. It identifies the process and the timeline of each MDS assessment, the admission, the full admission, quarterly and annual assessments, and what to do with it once you have the results, and how they fit into my care plan and my bedside care plan.
Hello, I'm Lori, and I'm an RN in Landville. Another problem we found was that the way MDS was viewed, it was seen as a standalone entity. We couldn't see how it related to care plan and the actual resident's care. Because of the comprehensive information that is entered into the MDS, areas of care are triggered, called CAPS, these clinical assessment protocols, and they can be addressed with specific interventions targeting the need for the resident. So we created a new care plan. We have developed a guide sheet to go on the front of it. Also a current information form with just immediate data that you might need. And our care plan is divided into 2 sections. The first section is called All About Me. It's on the top of each of those forms. And that's information that you collect from the resident when they're admitted. It's their preferences, what they require for care. And it's for each component of care. the second part, underneath, deals with the caps. And if these caps are triggered, the clinical assessment protocols are triggered, then that's what's care plan 2. That's something you need to look at for a resident. The second problem we realized that we had was that we weren't communicating the MDS triggers to all care staff. To resolve this, we developed a care plan communication book on our unit, and we've also developed a work standard about how that will work and how the information will flow.
Hi, my name is Stacy and I'm an LPN in Leoville. So part of the care planning process, we have a bedside care plan as well. And it's a very effective tool for us to have right at the point of care. Our current bedside care plans are quite vague. As you can see, there's lots of open spaces. Sometimes it's hard to read people's writing in there, and sometimes we miss specific care. Just we're not thinking of it at the time. So we created a new bedside care plan, and it's more in-depth, and you can personalize it better to your client care needed. It will help any new staff or casual staff that haven't been there all the time, that don't really know exactly what kind of care is specific to them. Also, if you are away for an X amount of days and you don't know of any update to that, it's very specific. And say, for example, if they are requiring assistance with any dental care, this goes right to the point where some people like to have their dentures in during the night as well. So it goes right to the point of care for that. So I think it's going to be a very beneficial tool for that. Also, this will be done on admission, so you can have the direct care right at the start.
Hello, I'm Alana. I'm the other co-lead for RPIW 52 team, and I'm the manager of the patient care coordinator unit here at the hospital. So this is a slide of our post-Kaizen value stream map. As you can see, a number of the Kaizen bursts were looked after during this RPIW as a result of the created and updated work standards, the creation of the new CAPS care plan and bedside care plan. And a very important piece was the communication loop involving the rest of the care team and family members in developing the care plan and closing that loop. And another result of that will be having that more accurate data that we're able to report. A 5S project was also part of what we did in our RPIW. This was done with the dry storage area at the Evergreen Health Centre. Prior to starting, we did a pre-Kaizen assessment, and our pre-Kaizen score was 1.14. After that, we went through the dry storage area. We red tagged 75 expired food items and 1 defective item. We then standardized the areas. We added labels when we organized the area. We also added an additional 15.6 square feet of shelving that the kitchen was able to utilize. When we did our post-Kaizen scoring, we ended up with a score of 2.3, which was an overall gain for the unit. We also did some work for maintenance. We developed an audit tool, work standards to help maintain the dry storage area, and Min worked on some ordering processes that will include a min-max number. So for this also is this is a slide of our target progress report.
So this is our event newspaper. We had a number of very key factors that we did to try to make the improvements. We're really proud on this side. We've got 100% on all but 2 items. The 2 that are left are really about training staff in the new processes, making sure everybody is up to speed at the Evergreen Health Centre on what the new process is to take that out of MDS and the CAPS, put it into the care plan, and then communicate that care plan to the rest of the team and to the family and the resident. As always in an RPIW, we learned a lot. People have a much better understanding of what MDS and the value of that as a tool in doing care planning. The users understand the need for the information flow. We really learned this week how much we think we're doing something, but we're not really doing it, or we're not doing it as well as we think we could. We're seeing also how things are done very differently. We talked to a few different facilities. We had people from who have a background in 3 different long-term care facilities, and nobody did it the same way. So this is about helping create some standards. And really at the end of the week, it's understanding how important it is to do and utilize a tool like this so that we can do the best possible care plan and provide the best care for the residents in our facilities.
Hi, I'm Diane, and my part in the RPIW program was a family resident participant. I have become more aware of the meaning of the family residents and the family care plan. A standard script to inform families, residents of the intent of the meeting was created so all the residents and families understand the meaning of the meetings. Thank you.